Hello, and thank you for joining today's webinar. Dr. Rachel Rosovsky will now begin the program.
Good afternoon, and welcome to today's program, Caring for Women Dental Patients on Antithrombotic Medications. I am Dr. Rachel Rosovsky, and I am honored to be moderating today's program. I'm a hematologist at Massachusetts General Hospital, as well as an associate professor at Harvard Medical School. My areas of expertise are thrombosis and hemostasis, and I am fortunate to be involved with many organizations to further research in these areas, including the Foundation for Women and Girls with Blood Disorders. We are so grateful to have Dr. James Curtis join us for this presentation today. Dr. Curtis is a board-certified general dentist with the Department of Dentistry, Prism Health Medical Group in Columbia, South Carolina. He has spent 39 of his 42 years of his career teaching and practicing in academic medical centers. He is the dental consultant for the South Carolina Department of Health and Environment Control for the state's CDC-sponsored Medical Dental Integration Program. And he has published widely in both the dental and medical literature. Dr. Curtis lectures regularly within the medical and dental communities and has shared his philosophy about dentistry's role in healthcare with national and international audiences. Dr. Curtis also serves on the Medical Advisory Committee for the Foundation for Women and Girls with Blood Disorders. Foundation for Women and Girls with Blood Disorders missions is to increase and ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. And to this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Since its inception, the foundation has focused on realizing its vision through these objectives, as you can see displayed here. To ensure the best sound quality during our program, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with Dr. Curtis and myself at the end of the program. And you can submit your questions during or after the presentation via the chat box in your control panel on the right side of your screen, and we will address them during the question and answer session at the end of today's presentation. And actually, I just want to go back. This was the slide I was talking about. Just to briefly mention, we want to build awareness about the unique needs of girls, women and girls, provide education and training, really ensure successful collaborations and coordination of care between hematologists and reproductive health specialists. I think that's what's unique about this organization is it is multidisciplinary. We want to link providers to turn good practice into best practice. And we want to translate and disseminate provider information and research and educate and support the next generation, our trainees, our fellows, our junior faculty of healthcare providers, really caring for women and girls with blood disorders. And I just want to thank everybody here for joining because you are going to be those educators for us. So the next few slides will detail our accreditation process, and in support of improving patient care, this activity has been planned and implemented by CINMED and the Foundation for Women and Girls with Blood Disorders. Continuing education credits will be provided, and a follow-up email will be sent to attendees explaining how to obtain 1 hour of CME CE credits for the program after its conclusion. And this activity is being provided independent of industry support. These are the learning objectives for today's events. Describe general and specific information regarding women taking anticoagulants who are undergoing various dental procedures that cause bleeding. Identify scientifically sound practice guidelines for managing women taking anticoagulants who require dental care that leads to bleeding, and recognize the importance of communication between medical and dental professionals. And I think Dr. Curtis is really going to give us some guidelines about that. We have the following disclosures to share. All provider employees in control of content have indicated that they have no relevant financial relationships to disclose. All attendees will receive an email an hour after the program's conclusion with the evaluation and this link to claim your 1 hour credit. And the accreditation overview is also available as a handout. And we're really looking for your evaluation, what we're doing well, what we could do better, what you want to see in the future. So before we begin, we would like to do a quick poll to see how many people are joining us today with others. So please take a moment to answer the poll questions on your screen, and we'll ask a few questions to assess your knowledge before the presentation. So the first question, please tell us how many people are joining you today for this conversation. You're watching by yourself, one other person, two other people, or three or more people. Okay, second question. Active bleeding following a routine dental extraction is usually controlled with how many minutes? And please select one of the following: 3 minutes, 30 minutes, 90 minutes, or 180 minutes. Next question is, patient not taking any antithrombotics has advanced periodontitis and needs 29 teeth extracted. Blood loss may be up to how many milliliters? 50 milliliters, 150 milliliters, 350 milliliters, or 1,500 milliliters. Again, this patient is not on any antithrombotics. This is a patient taking warfarin, 7.5 milligrams daily, and it's considered safe for dental care, causing moderate bleeding if the INR of the day of the procedure is less than or equal to, and select one of these: 1.5, 2.5, 3.5, or 4.5. So again, patient taking 7.5 milligrams of warfarin. What INR is safe? Current literature recommends a patient scheduled for a deep cleaning who is on apixaban 5 milligrams twice a day may do one of the following: continue their medication, hold the apixaban for 1 day, hold the apixaban for 2 days, continue the medication or hold for 1 day, or hold for 1 or 2 days. So you have a lot of options. Please pick one. Next question is, patient on ticagrelor monotherapy, 90 milligrams twice a day following PCI 10 months ago, should pause their medication for how many days before an extraction? 0 days, 1 to 2 days, 3 to 5 days, or 6 to 8 days? Thank you for your responses. We will be sharing those at the end, but I am just honored to share now and turn the slides over to Dr. Curtis for his presentation on caring for women dental patients on antithrombotic medications. Dr. Curtis.
Rachel, thank you very much for allowing me to be here, and to the foundation, it's quite a privilege for me to be participating in a webinar like this. We related financial disclosures a moment ago, and I don't have any financial disclosures to make, but I will disclose the fact that I, as a general dentist, am really intimidated giving this presentation to a group of individuals that I know are mostly hematologists, because you guys are the ones that I lean on and seek information from, but I do want to share some of my experiences and where we stand with our current understanding of the literature. So let me see if I can get my slides to go forward. Again, the objectives that were related earlier are going to be expounded upon just a little bit. I want to describe some of the bleeding risks that are associated with various dental procedures, because quite frankly, that information doesn't exist anywhere in the literature. I have searched the literature dating back for 40 years, and neither textbook nor published manuscripts relate specifically how much an individual is going to bleed when they're undergoing a particular type of dental care. Also want us to look at the milieu of literature that's out there, as well as the various guidance that's published by different professional organizations, both within the medical field and the dental field, as it relates to the paraprocedural modification of antithrombotic medication regimens. And then for you as physicians to advise your patients and to also help dental practitioners understand the necessity when it's needed to temporarily interrupt an antithrombotic medication. So just a brief background, if you look at the literature right now, we estimate that there are about 8 million people in the United States who are taking some type of quote unquote blood thinners. And the patients that I deal with, that's what they continue to refer to them, regardless of whether they're an anticoagulant or an antiplatelet medication. And in my world as a general dentist, it is really bad news for me to encounter excessive or uncontrolled or prolonged bleeding from a procedure that I performed on a patient. It can have an adverse impact on the outcome of the procedure that I'm performing, but it's certainly unwelcome to me and my patients. And the medications that cause increased bleeding are the low molecular weight heparins. We're basically going to skip any conversation about those today because not many folks are using those in an outpatient setting, but we will be touching on vitamin K antagonists, the direct oral anticoagulants, and antiplatelet drugs, be it aspirin or one of the P2Y12 blockers. So I want to share with you what I consider to be the dental practitioner spectrum here when we look at this. On the left side of your screen is one of my favorite paintings of all time, Edvard Munch's The Scream. A lot of times when a patient walks into a dental office seeking care and they relate to the dental staff that they are taking some kind of anticoagulant or antiplatelet medication, the dental office basically just wants to put their hands over their ears and run away screaming. And then you have a really, really small percentage of dental practices who are like the little fella in the middle. So you're on Xarelto, not really even sure how to spell it, let alone what it does, and they're out there looking for answers on Google. And sometimes when that happens, those are the patients that I or my residents are called into the ED to help control postoperative bleeding when someone hasn't recognized that. But fortunately, most dental practitioners are like the guy on the right. They are knowledgeable, experienced, and relatively comfortable in providing care, but oftentimes need some additional support from a patient's physician. And part of the confusion spectrum, as I call it, is the fact that if we look at both the medical and the dental literature, Bleeding risk related to dental procedures is listed in quite a number of categories. The typical patient, well, what is a typical patient? A typical patient in my world may not be a typical patient in your world. What's a higher risk patient? Moderately invasive surgery, more invasive surgery. Well, yeah, we're not putting burr holes through somebody's skull. We're working in the mouth and that type of thing. So what constitutes that? But the manuscripts use these terms, and they use the conventional terms such as low or low to moderate and high. And when we look at the guidance that's presented from various organizations and within different publications, those guidelines can range from, well, you should consult a physician about what to do, to maybe you shouldn't do as much when you get started so you can assess how much the patient is going to bleed when you do something, to flat out a statement such as do not interrupt the medications. They're taking them to prevent some type of thromboembolic event. Heaven forbid that they have another stroke because you needed to extract a tooth, or to temporarily interrupt the medication, depending upon what the medication is, from anywhere between 1 and 7 days. Or, as noted in quite a number of manuscripts, this area really hasn't been well studied and we don't have it specified. So when I look at the literature and see these types of things, I, as a practitioner who dwells in an academic medical center and treats sick folks and sees people on antithrombotics all the time, I feel fairly comfortable taking a stand and saying, this is the literature I'm going to adhere to, but other folks may not. So we need to have bidirectional communication. You as physicians, be you a hematologist, cardiologist, neurologist, internist, family medicine, any person out there who is prescribing these drugs, need to help us as in the dental world understand what is the patient's real current risk of a thromboembolic event. In other words, can we temporarily interrupt these medications? And if some special study that needs to be done, maybe help order that or guide the dentist in what's appropriate. And then helping us with the management, or the patients with the management, about when to interrupt and when to restart antithrombotics if appropriate. Dentists need to work with medical specialists to help them understand what's the risk of bleeding based on various dental procedures, because your concept of what constitutes a risk of bleeding in a dental procedure is more likely than not based on your own personal experience, which may have been rather minimal if you've grown up with a healthy mouth, or you may have had a patient that has had a disastrous outcome, and all of a sudden you classify all dental procedures as having high risk. And so you need to also get from the dentist, what's the nature of the dental treatment that's to be performed? And if we can't perform it right now, what are the consequences of delaying or foregoing that dental care? Because sometimes the consequences can be rather significant. So again, for us as dentists, we're trying to figure out, first and foremost, with our patients who are on antithrombotics, what is their real thromboembolic risk at this particular juncture. I feel fairly comfortable understanding the literature that a patient who has had drug-eluting stents placed following PCI is supposed to be on dual antiplatelet therapy for 12 months. But what do I do if that same patient comes in and they're now 6 years out from those placement of the drug-eluting stents and they're doing okay? Do they need to be on that? And is their risk of another cardiac event as high as it was during the first 12 months? And then what kind of bleeding am I going to experience during the dental treatment I perform? And if I've got to interrupt their meds, when should it be done and when should I get them back on there? And the fourth item is, I think, is one in which we are all fairly comfortable with right now, realizing that bridging protocols are usually not recommended for the types of procedures that we do, even if someone does have an extreme thromboembolic risk. And when we get to the question and answer session, if we have time, I may pose a question to the group and to Dr. Rosovsky about a patient that we recently saw who had, I think, the most extreme thromboembolic risk that I've ever encountered in 45 years. So let's talk about what I put in quotes, normal bleeding from dental procedures. And you need to be aware, as the asterisk indicates, that all of the data that I am presenting to you are attributed to me, nobody else. But this is what I have come up with over time. And a lot of this has been because I have performed a lot of dental care in the operating room where assessing and evaluating and tracking blood loss is part of the operating room protocol. And so first and foremost, anesthetic injections. Most people coming to the dentist are going to be numbed up for something. Well, it usually doesn't cause a lot of bleeding. How about dental cleanings? Well, if the tissues are inflamed and the cleaning is below the gingival margin, we're going to expect some bleeding in a 4 to 6 tooth segment. Scaling and root planing, which is very vigorous cleaning down deep below the gingival margin and is much more invasive, is going to cause a little bit more bleeding. Taking a tooth out by just literally elevating it or extracting it with a forceps, something that can be done within a minute or two, doesn't cause much bleeding. When you start thinking about periodontal surgery, as long as extreme manipulation of the bone is not involved, we're going to have about 20 milliliters of blood loss with every 4 to 6 tooth segment. Dental implants don't cause a lot of bleeding. One reason is because when the implant is placed, we get tamponade down within the bone of the implant fixture having been screwed into the bone. Routine soft tissue biopsies, and again, by routine, I mean basically a non-malignant lesion or one that's not highly vascular, but something that we would see that would be a fibroma where it could just be snipped off and we could get primary closure, or we could take it off using electrocautery and then submit it. But a complex biopsy on a large lesion that is suspected of being malignant is not going to fall within this category. When we start talking about complex extractions, these are the ones in which the dentist removing the tooth has to begin to cut into bone. And when we cut into bone, particularly if the incisions in the bone go into the medullary spaces, we see increased bleeding. Same thing holds true for the excision of large bony exostoses. If that exostosis is so large that it is more than just cortical bone that is going to be shaved off, but has medullary spaces within the cavity of the exostosis, you're going to get more bleeding there. Then when we start doing that extensive or complex periodontal surgery where we're manipulating bony tissues, we can have as much as 50 to 100 milliliters of bleeding in a surgical procedure. Or when we're taking out all the teeth in a jaw or in both jaws, up to 200 milliliters of bleeding. Or if we're doing multiple implants in both jaws, gonna have experience more bleeding. And then the last thing I put down there is surgical procedures that involve highly inflamed tissues, maybe up to 350 milliliters of blood loss in that regard. And as you folks look at this, you think, well, gee, that's not a lot of bleeding. You know, that's rather minuscule compared to what somebody that's having a hysterectomy done or some other type of procedure. But when it occurs in the mouth, it affects the patient differently than it may affect the patient otherwise in terms of how the patient is able to handle it. So normal bleeding, again, a person not taking any antithrombotic medications should be controlled within 30 minutes max. The site might ooze a little bit because we have some enzymes in our saliva that induce a little bit of thrombolysis. And so it might ooze a little bit until we get an absolutely great fibrin clot. It's important for patients to apply firm, continuous pressure with a gauze pack, and it needs to be moistened, not dry. If it's a dry pack when it goes in, when they go to remove it, the fibrin clot may extend into the cotton gauze, and they may end up pulling the clot out. Generally recommend that they apply pressure for 5 to 7 minutes or and do that as long as the gauze is not saturated with blood. If it's a little bit pink, that means it's slowing down, and probably most of the bleeding you're seeing is not really blood, it's blood mixed with saliva, and so you have that tinging of that. We do know that patients who chew on their gauze pressure dressings or talk continually while they're in place have prolonged bleeding, and that if they don't follow our postoperative instructions completely, that can lead to prolonged bleeding or recurrent bleeding. And in the dental literature, there are a couple of manuscripts which refer to the concept of post-extraction bleeding, and that's one in which active bleeding continues for up to 8 to 12 hours following surgery. And if you read these articles, what they state is if this is happening, this is when a patient is going to need to probably have a transfusion. They may need a platelet transfusion. Something else is going on, but they're going to have to typically go to a higher level of care in order to get that bleeding controlled. It's no longer something they can do at home or that a dentist typically can do in a dental office. So what are the risks of bleeding to dental procedures? And this is, again, the Jim Curtis breakdown. I consider that there is low to no risk for routine dental cleanings in a healthy mouth. And I hope all your mouths are healthy and your visits with your hygienist are pleasant experiences, and you spend more time getting to chat about things than you do have somebody, ending up beating you up. When we fabricate as a dentist, some kind of removable denture, whether it's a partial denture or full denture, it doesn't involve anything that causes bleeding. Neither does orthodontic treatment for kids or adults, whether it's braces or aligners. Most of the time, dental restorations, fillings, crowns, veneers, unless the tissues are highly inflamed, are going to cause very little, if any, bleeding. Root canal treatment, in which a non-surgical approach is taken, should cause essentially no bleeding also. And submucosal, or what we term as infiltration anesthetic injections, are also very low risk of bleeding. Moderate risk, in my estimation, is when the tissues are inflamed and the cleaning needs to extend beneath the gingival margin. You're going to see bleeding with that. Likewise, with non-surgical periodontal therapy, oftentimes referred to as a deep cleaning or scaling and root planing, is taking place in a mouth that has highly inflamed gingival tissue. Limited periodontal surgery, we talked about that in terms of no more than 2 to 6 teeth and not cutting on any bone. Simple extractions up to 1 to 3 teeth. Again, no cutting bone involved at all. We've already talked about soft tissue biopsies and simple implant placement and dental nerve blocks. Now, if we look at this slide, I've introduced this to talk a little bit about dental anesthesia, and thanks for the folks, Dr. Netter's illustrations. showing a mandibular nerve or inferior alveolar nerve block. Infiltration is basically submucosal and poses no risk unless you happen to nick or sever an arteriole. And I've had that happen a couple of times over 45 years, where within 2 or 3 minutes, somebody's got a hematoma that I could probably evacuate out 15 milliliters of submucosal blood. But with an intramuscular block, because we don't know exactly where the nerve bundle lies, we're having to work within an anatomic constraint that puts us in contact with larger vessels and deeper spaces that are contiguous with fascial planes. So if we did penetrate or lacerated the inferior alveolar artery while giving this injection, that bleeding could then go into the lateral pharyngeal space, and we could have a real serious problem on our hands. High risk of bleeding is primarily, again, things that require cutting of bone. So it's complex extractions, impacted teeth, or when we start taking out all the teeth in one jaw or all the teeth in the mouth at one time. Those large exostoses or complicated periodontal surgery, again, we're manipulating bone. Same with full arch placement of implants or surgical procedures, even though they're more confined to a smaller number of teeth or a smaller segment if the tissues are highly inflamed. And these two clinical illustrations attempt to show a little bit about what I'm discussing. The case on the left is a lady who had an impacted canine tooth. The tooth was being extracted along with her other teeth, which had routine dental disease, but this lady was on a sort of a really odd combination of medications because she had an undiagnosed thrombophilia for many years, and she was on ticagrelor and twice-a-day Lovenox. And so we had to be really careful in doing her surgery. The person on the right, in spite of the fact that they may tell me that they brushed their teeth that morning, haven't brushed their teeth for months or years. And if you look closely, you can see that the gingival tissue is edematous and it is highly vascular. And when we make incisions in that kind of tissue, it is going to bleed significantly. So let's look again at the specific drugs that we want to talk about today. Warfarin was the first one that was approved back in 1954, so it's been around for almost 70 years. And back in the day when it was the only med that was out there, I got to the point where I could live my life pretty much fat, dumb, and happy dealing with patients taking warfarin because I had a little thing known as a prothrombin time. And when I was first introduced to that, I felt pretty comfortable that as long as someone's prothrombin time wasn't any more than 1.5 times the control, that I could safely perform surgery on them. And then along the way, we had INR introduced, and that improved our ability to assess these folks. And as we saw folks taking warfarin who had an INR, we began to understand that we could work on them as long as their INR was basically within the normal therapeutic range. Then in the 2000s, the direct oral anticoagulants hit the market. And you guys are very familiar with these folks, with these medications. The drug that I see patients on more often than not is apixaban. Probably second is rivaroxaban, and I can't recall the last time I've seen anyone taking dabigatran or edoxaban or betrixaban. But we see a lot of people taking Eliquis these days. Oral antiplatelet drugs are a big, huge variation here. We have the aspirin, which was only FDA approved, even though it's been around for well over 100 years, only approved for its antithrombotic effect in 1980. And even though the drug itself has a short half-life, the duration of action is the life of the platelets that were exposed to that drug. We've had since 1997, clopidogrel came along, and then prasugrel, and then most recently in 2011, ticagrelor was introduced. And all of these meds irreversibly affect platelets. And you guys know that. So where are we in terms of continuing or stopping these medications on a temporary basis? With the warfarin, anybody that is receiving dental care that would put them at low to moderate risk should, in my estimation, just continue their warfarin at a regular schedule. But however, if there's a doubt about whether or not their INR is therapeutic or has been therapeutic, probably would be wise to do an INR the day of procedure. And the reason I say that is because I have seen folks who have gone to their monthly Coumadin clinic and have had an INR of 2.2, 2.5, 2.7, 2.2 for months on end, and then end up in a dental office and have a extraction performed, can't get them to stop bleeding, and when they show up in the emergency room and they draw an INR, the INR is 5.2 for whatever weird reason because of the vitamin K metabolism. And again, high risk for dental bleeding, if we always do an INR the day of procedure, and most of the manuscripts out there and most of the guidance provided by organizations say that it's generally safe to proceed with the surgery if the INR is at least 3.5 or less. Sometimes we feel a little bit more comfortable if it's closer to 3.0. And there's some organizations in Europe that say it's safe to proceed even if the INR is 4.0. So again, there is still a little bit of debate about that. Regarding DOACs, I think the two major sources that are out there that I really rely on are the manuscript that appeared in Chest back in 2022, and then the publication in 2020 in the Journal of the American Heart Association. And from that, we have gotten to the point where we feel very comfortable in our practice managing folks taking direct oral anticoagulants. If it's a low to moderate risk for bleeding, just continue. But those guidelines that are, or the manuscripts that are listed there, do suggest that also a one-day temporary interruption is okay. And if there are high risk bleeding from dental procedures, temporary interruption for 1 or 2 days is necessary. And to that end, in our department, in order to try not to pose a risk to a patient of having another thromboembolic event, we've sort of tried to modify that a little bit. And pretty much anybody that comes into our practice in the hospital who is at low to moderate risk, we're going to continue their medication regimen as it's been prescribed. If it's a high risk procedure, multiple extractions in extremely inflamed tissues, and they're only taking their meds once a day and they take it in the morning, we ask them just to withhold that on the day of the procedure, and we schedule the appointments sort of late in the morning if we can. So we've given them a little bit over 24 hours since their last dose of medication. And then if their bleeding is well controlled, they may resume that the next day. So they're only off of that medication for 1 day. Likewise, if they're on the BID regimen and are taking it in the morning and the evening, we ask them to hold their nighttime dose the day before surgery and hold their morning dose the day of surgery, and not to administer the evening dose after surgery. And if they're back to a good clot and no bleeding, get back on that medication the next day. And antiplatelet meds, I think, pose about the greatest level of confusion, and that's why I have the asterisk by that. It again depends upon whether it's aspirin, and if it's aspirin, is it an 81 milligram dose of aspirin, or is it 250 milligrams or higher? Because as a dentist, I see people bleeding much differently on low dose aspirin than I do on higher dose aspirin. But if the risk of bleeding is not high, regardless of whether it's aspirin or one of the P2Y12 inhibitors, we generally recommend that they continue. Although some organizations say that they should temporarily hold it for a day. Well, I'm not sure what good it does to hold a medication for a day that has inhibited platelet function for the life of the platelets, but it's out there. And for high-risk dental procedures, it states again to hold for 1 or 2 days based on the 2 references that are there. And I think in general, we know that we need to interrupt the ticagrelors and the clopidogrels for longer periods of time than that. And certainly if someone's taking 325 of aspirin, I need to have them hold that for a longer period of time or be prepared to deal with things in a different manner. And these are some of the things that I and my partners and the dental profession do. We use epinephrine containing local anesthetics most of the time anyway, because believe it or not, they're safer than plain anesthetics. Electrocautery, we've already talked ad nauseum about gauze hemostatic dressings. If we can obtain primary closure through suturing, we do that. You can use oxidized cellulose or absorbable gel sponges to try to help form a scaffold for a good fibrin clot to form, or if need be, apply topical thrombin. And then really useful to us if we have people that are at high risk of continuing to bleed is to use a TXA rinse for several days if necessary. We took that back from our days of treating hemophiliacs and applied that over into the medication-induced bleeding. So as I close out here, I want to issue some words of caution, because everything that we talk about based on the research is mathematics, you know, those statistics. And our patients are not numbers. Our patients are living, breathing human beings. And I hope when I get finished with them that they're still living, breathing human beings and they haven't bled out because I've done something stupid. But not every patient responds to a medication within 2 standard deviations of the mean. And for goodness sake, we have this polypharmacy. And think of all of the enzymatic pathways that are affected by other drugs that may also affect the metabolism of the antithrombotics that are being administered. And then comorbidities. I might have a young, relatively healthy young man who had a DVT for some reason, and I need to take out a bunch of teeth on him, and he is otherwise healthy and robust. And I have a 87-year-old individual who's got comorbidities that extend, 2 pages on Epic as I look at the comorbidities. And she's sitting in my dental chair and I'm really concerned, you know, is she going to make it through this procedure? She appears to be so frail because of the comorbidities. I'm not really sure that an individual like that is going to do well. They're not going to exsanguinate, but she's not going to do well if she has 10 or 15 milliliters of bleeding after I complete my procedure and she goes home, because it's going to mix with her saliva, and she and her kids or her caregivers are going to think that that 15 milliliters of bleeding is closer to 2 quarts, and she's not going to be a happy camper in that regard. So last few things before we get back to the polling questions are the references. And I think from what I understand, this presentation is being made available to you. And all of these references do have their links in there so that you can click on the links and go read the articles themselves or go visit the websites of the professional organizations. But there's a lot of stuff that's out there, but it's still not all crystal clear as to where we stand. And that, I believe, the picture of the big old bull elephant brings me to the end of my time. And I think we're ready to repeat the polling questions again. And this time we will show the answers. So first one, active bleeding following a routine dental extraction is usually controlled within how many minutes? 3, 30, 90, or 180? And are the answers to that coming up if people are participating? Oh, okay, very good. Next question. And that is the correct answer is 30 minutes based on the talk there. A patient who is not taking any antithrombotics has advanced periodontitis, which means that they have a lot of inflammation and they have 29 teeth that need to be extracted, meaning that they're going to have teeth extracted in both jaws. Blood loss may be up to 50, 150, 350, or 1,500 milliliters. And again, we've got a divided group there. Certainly 150 milliliters is included in the 350 milliliters. But yes, I think that shows that there's going to be some significant bleeding. So that's a good distribution with that there. I would say that the correct answer is 350. Patient taking warfarin 7.5 milligrams once a day is considered safe for dental care, causing moderate bleeding if the INR on the day of the procedure is less than or equal to 1.5, 2.5, 3.5, or 4.5. And 3.5 is the preferred answer there. Very good. Next one. Current literature recommends a patient schedule for a deep cleaning and who is taking apixaban 5 milligrams twice a day may either continue the medication, hold the medication for 1 day, hold for 2 days, continue the medication, or hold for 1 day, or hold for 1 or 2 days. And again, that is, looks like if we combine all those together, that is either continuing the medication or just temporarily interrupting for 1 day is the correct answer. But this again, I think, shows that there is not a lot of clarity within the literature and everything. And then our final question. Patient on ticagrelor monotherapy, 90 milligrams twice a day, after having had a PCI 10 months ago, should pause the medication for how many days before dental extractions? 0, no pause, 1 to 2 days, 3 to 5 days, or 6 to 8 days. And we've got a good bit of disparity on that. 50% say just 1 to 2 days, and the other 50% say either 3 to 5 days or 6 to 8 days. And I think for me, with someone on ticagrelor, I want them off that medicine for at least 3 to 5 days and everything based on what I understand the literature to be. So thank you for participating in the poll.
Thank you, Dr. Curtis. What a whirlwind tour. I feel like I have so much information that I learned from you. Really, really helpful. So at this time, we're going to proceed with question and answer part of our program. So just as a reminder, you can submit questions via the chat box in your control panel. So please, we would like your questions. I just had one clarifying question when you were talking about interrupting DOACs, where they needed to hold it either if they were on a twice a day, they would hold it the night and the morning. And if they were on once a day in the morning, they held it in the morning. What if there's someone that takes that once a day in the evening? Would they hold it just the once a day in the evening? I just want to clarify that.
Yeah, and thank you for bringing that up. I need to introduce that into the presentation because I'm bumping into some people who are taking that in the evening. What I would have them do is hold the evening dose the day before the procedure, and then we would prefer to schedule our surgery in the early afternoon. So that we give them the maximum amount of time based on the drug half-life for it to clear. And the reason I talked a moment ago about us wanting to perform the surgery in the late morning and now in the early afternoon is we'd like to be able to complete the surgery and have an adequate period of time following the surgery for the patient to get back home and determine whether or not they're going to be stable or not, or do they need to come back and see us that same day while our office is open as opposed to having to go to the emergency department.
So just to clarify, if they're on once a day drug and they take it in the evening, they're going to hold the evening dose. So essentially they're going to be off of it for about 36 hours when they get to you.
That is correct.
Okay. And then I'm wondering, I have a lot of patients that take supplements, and some of these supplements can affect the coagulation system. Is that something you routinely ask? And if you do, what are your thoughts about that?
Yes, we routinely ask, and remember that that drink that I was talking about that I should have fixed this morning before I got this presentation going. I should have had that. We have patients that do take supplements, and when they start talking about their supplements, for us, we try to investigate those supplements because I know that quite a number of them do influence bleeding. But again, I am frustrated because I ask patients repeatedly in different languages, do you take supplements? Do you take medications that you don't have a prescription from a physician for? Do you do this? Do you do that? And they go, no, we don't. And then we get to the end of our procedure and they have been bleeding and the blood has been flowing like the Mississippi River, and you're fighting to get it controlled, and you're getting your assistants to come in and help you do this, that, and the other. And you say, are you sure you? Oh, well, yeah, I am taking Larnica root or something. And okay, well, let me go look that up. And sure enough, I find out that's that. So yes, those are very important things also.
Yeah.
Thank you for bringing that up.
You are welcome. And I think that we as providers, we can encourage our patients to let their dentist know what they're on. I always ask, and I sometimes fall in the same thing, so I try to ask them in different ways. You're taking any powders, anything from the vitamin store, anything that you're putting in your mouth that's not prescribed by your drug that could be considered. But I think that's really important. I had another question. you know, a lot of times people will have an acute blood clot, right? And in the acute setting, we really don't want to hold the anticoagulation for the first 3 months, right? Because of the risk of clotting. So are there, I mean, I'm sure there are, in most situations, we can just wait the 3 months, except if it's an emergency. What are your thoughts about that?
And that is oh so true. That's why it's important for us to understand what that thromboembolic risk is.
Yeah.
But every now and again, we will run into someone who has had an event. They've had that acute thrombotic event, and they're in our office, and they now have a full-blown submandibular fascial plane infection, and they've got to have an extra oral IND, and they've got to have that. And those are the kind of people, they're going to the operating room. We're going to be there with support from other individuals, and if needed, when it's all over and done with, we'll have the ability to admit them to the hospital to manage their continuing care.
Yeah. I'm wondering, and maybe you could explain this to me. You said for people that have a high bleeding risk procedure, you want the Coumadin less than 4.5. Well, in general, the goal of Coumadin, the INR, is 2 to 3. So if you are okay, sorry, 3.5, you want the INR to be less than 3.5. If you're okay with doing a procedure with an INR of 3.5, why not be okay with somebody on a full dose or even a prophylactic DOAC, because it's the same thing?
I'm basing that off of the what's published in the literature.
Okay.
And so again, that's why, at least for our lower moderate risk bleeding, I would prefer that they not discontinue their DOACs, that they stay on that. However, you know, I've seen some cases in which patients were having relatively routine things done, taking apixaban, and I didn't expect them to bleed much, and I'm having to work really hard for 30 or 45 minutes to get them to stop. And I wish that an INR was, at least as I understand it, and please point me into the source of the literature, I wish that an INR was an effective test for me to run on someone taking that. And all, but it hasn't been enumerated in everything that I've ever been aware of. So
I was just perplexed because an INR 2 to 3 is full therapeutic, which would, in my mind, it's equivalent to being full therapeutic. There are anti-10A levels that you can get with apixaban and rivaroxaban. They're not widely available in most institutions. We often get them if somebody comes in with, you know, active bleeding and we're thinking about reversing them, but it's not easy. They're not easy to get. And then the other issue is we're not really sure what the ranges mean. Like we have this big range of like what's, you know, like a normal might be 69 to 369. So that's very hard to sometimes interpret. But that is, thank you for answering that.
And that's the way it was when we started using INR versus proton. You know, when it first came out, is we thought, well, you know, we just were automatically sort of assuming that an INR of 2 was equivalent of a proton that was a 2, and we've learned differently over time.
So Dr. Curtis, we have 1 minute. So in 1 minute, what advice can you give us providers on how to communicate with dentists who may not have your breadth of experience and comfort? And you have to answer this in 1 minute because we only have 1 minute, but I think that would be really helpful for us.
I think the best thing would be to assure these dentists that the patients that are taking these medications need to be on the medications, and that if they are at a point where their risk of another thromboembolic event is not that high, that it is safe to temporarily interrupt for a very, very short period of time. But if possible, if there's anything that can be done with local measures to control that bleeding, to keep them on their meds and everything in that regard, but know that they've got medical support if they need it, if there's a problem that arises.
Okay, and everyone will have a link to this webinar, so we could also just send it along to our dentist or our patient's dentist. So wow, Dr. Curtis, thank you so much for your presentation today. I have to say, it's really such a wealth of information and really so helpful for everyone, because everyone needs to go to the dentist and there's so many people on these anticoagulants. So the foundation is pleased to provide this program at cost, at no cost to attendees, no cost. You will receive an evaluation following the program in your registration email in about an hour, along with a link to claim your continuing education certificate. And again, please leave us feedback. And a recording, like I said, of this presentation will be available next week. And I encourage you to share it with your colleagues, your trainees, and certainly your patient's dentist. So again, on behalf of the foundation, we'd like to invite you to an upcoming program, case conversation called Trends in Dedicated Care for Females with Bleeding Disorders within the United States Hemophilia Centers. This is going to be held on Monday, December 18th from 1 to 2 o'clock. And you will find this information and registration at the Foundation for Women and Girls with Blood Disorders. So again, I want to thank everyone for your attendance and your participation today. And we really look forward to future participation in foundation programs. And again, please provide us with feedback and what else you would like to hear from us. And just a big thank you to Dr. Curtis and of course the foundation. Have a wonderful afternoon and thank you again, everybody.
Thank you all very much.